Good evening, everyone. Welcome to this webinar at Believers Church Medical College and Hospital. Today, we have an interesting webinar in neurology. And to moderate this session, we have two illustrious interventional neurologists. The first person is Dr. Anil Kumar Sivan, consultant neurologist and specialist in interventions. He completed his undergraduate from Kottayam Medical College, went on to do his MD General Medicine from the prestigious All India Institute of Medical Sciences, New Delhi, and DM from the prestigious NIMHANS. After a short observatory training at Calgary Foothills Hospital, Canada, he went on to do a fellowship in neurointerventions from Rajagiri Hospital, Kerala, and is currently the consultant interventional neurologist at the Department of Neurology in Believers Church Medical College and Hospital. The second person is Dr. Deep P. Pillai, who completed his undergraduate from Trivandrum Medical College, post-graduation from Jabalpur, and went on to do his DM Neurology at Trivandrum Medical College. After completing his fellowship in neurovascular interventions from KEM Pune, and with more than 1,000 independent DSAs and more than 100 intracranial neurovascular interventions behind him, Dr. Deep P. Pillai is an accomplished interventional neurovascular physician at Believers Church Medical College and Hospital. So I welcome both of you to this international webinar, and let me hand over to our first moderator, Dr. Anil Kumar Sivan, to introduce and to let us know about the speaker for the day, Dr. Anil Kumar Sivan.
Thank you, Dr. Jacob Jasuran, for that kind words of introduction. It's my great honor and it's a cherished moment to introduce our beloved guest speaker, Dr. Tito Tundi Lidikula. He is currently the consultant neurologist at St. Olav University Hospital, Norway. And after completing his undergraduate from Kerala, India, he went on to do an observatory training in Norway itself. And after interning at Michael Rose Hospital in Chicago, USA, he went to specialize in neurology at VCU, Richmond, USA. Then he completed his PhD doctorate in acute stroke, that too in Norway, and then worked as a consultant neurologist at University Hospital Bergen, Norway. He's a great person. He has nearly 20 articles in various international journals and one textbook, one chapter in a textbook of acute ischemic stroke. Welcome, sir, once again. It's a great privilege. And let me hand over to my colleague, Dr. Deep Pillai. Dr. Deep.
Thank you, Dr. Jacob and Dr. Anil, for the kind words. Now, my job is to introduce the topic. So, today, one day after celebrating the World Stroke Day, that was in October 29, 2020, stroke is a leading cause of death and disability worldwide. And the stroke systems of care, the approaches to treat stroke care delivery, and the availability of resources vary considerably across different geographic locations. And in India, the statistics indicate that there is roughly around 1.5 million stroke cases every year. And that comes to an average of around 3,000 to 4,000 cases every day. In Kerala, the Trivandrum Stroke Registry, which was published in 2009, the data from the registry shows that there are around 135 cases of stroke every 1 lakh population, and 3/4 of those strokes are acute ischemic strokes, with a case fatality rate of as high as 25 to 35% at the end of 1 month. But the public awareness about stroke is very much lacking, and when it was studied in an urban population, it was found that only 55% of the urban population were aware of at least one stroke symptom, and only 16.2% of the population were aware of 2 symptoms, and only 6.2% of the population was aware of all the 3 symptoms of stroke. In last 25 years, we have seen a paradigm shift in the acute management of stroke. when the first NIMS RTPA trial was published in 1995. So our life is almost synchronous with the changes that have been happening in the field of acute stroke management. It was in late 90s that we entered the medical college, and at that time, stroke was being managed in the verandas as well as wards of the hospital. But since the RTPA trial, many things have changed with the introduction of stroke care units as well as dedicated stroke teams, and the number of thrombolysis has also been increasing over the period of time. The next landmark change came in 2015 when the large vessel strokes, for the management of large vessel strokes up to 6 hours, mechanical thrombectomy or endovascular clot removal was approved as a standard of care. But even then, there is a huge gap between the demand as well and the supply of these acute stroke management techniques. So today, without wasting much time, after this brief introduction, I hand over the proceedings to Dr. Tito for his illustrious presentation and his insights into the comprehensive management of acute ischemic stroke.
Yeah, hello, very good evening. Thank you very much, Dr. Deep and Dr. Anil Kumar, for those generous introduction, I would say. It is always a great pleasure and an honor to be with people back at home country. I myself had a stint with the Believers Church some 2 years back, and I really cherish those moments because of the variety of cases you have and how a single doctor in India can influence a patient. So I was really impressed and I was really happy to share some time there. Today's topic is about acute stroke, and I should say that my time there, I was very happy to see how things have changed in India as well. So many drastic changes had been there compared to the time when I left India. So I think I will just go directly into the topic. I hope you are able to see my screen. Yeah, so it is about comprehensive stroke management. Before I go into the stroke management itself, I might take an off track and talk a few minutes about evidence-based medicine in stroke, because that's how we set up our whole stroke management. And whenever I talk about evidence-based medicine, people would sometimes ask, what does that mean? I have been in practice for the last 30 years, and are you saying that whatever I had been doing did not have any evidence? And some young colleagues might think that evidence-based medicine is all about numerous number of studies which shows various finding in various directions. So so I would like to talk a few minutes about evidence-based medicine. To make things very simple, I would like to take an example from Norway. Here in Norway, I know a middle-aged woman who came to Norway from India. And the first thing that she noticed was that Norwegians are far taller than an average Indian. And she is true. Norwegians are about half a feet taller than an average Indian. And the next thing that she noticed was that we from India, we mostly use rice as our staple carbohydrate diet. And people in Norway mostly use potatoes as their carbohydrate source. So it didn't take her very long before she concluded that it's the potatoes that make Norwegians taller. Well, for us who are from a medical background, we might say that there are multiple factors involved in the average body height. There is a definite genetic factor, there is a race factor, then of course there is a nutrient factor, and mostly that could be protein. But if you think seriously, you cannot really contradict her hypothesis without actually testing it. It could be that the carbohydrate composition in potato and rice are different, or it could be that some of the plant hormones in potatoes are different from rice, making Norwegians taller. It's unlikely, but we cannot refuse the hypothesis without testing it. Now, how can you test it? Well, you can take a few people we can take a few people from, for example, India, and then compare their diet habitat and check if people of Indian origin are mostly using rice and if that is related to their height. But it is going to be an observational study, and we know that all these observational studies has its own limitations. And we have all seen so many studies coming out. For example, those who are eating dark chocolates are usually healthier than others, and therefore dark chocolate is good. But we also know that people who usually eat dark chocolate, they are likely to be more health conscious. They are likely to eat less sugary food. So there are so many confounders here. So observational studies has its own problem. Now, another way of dealing with it could be that we can do a randomized control study. In this case, for example, you can take 100 kids, 100 children, 50 Norwegians and 50 Indians. You put them into one diet of potato, and the other group, you put them into a rice diet. Follow them for 10, 20 years and see if the average height is different. Yes, if you can do that, then you can prove your hypothesis or disprove your hypothesis. But is it possible? It's almost impossible to do that because, first of all, it's unethical to take 100 kids and put them on a diet for many, many years. Second, it's not easy to monitor these patients or these subjects, whether they are following the diet. So practically, this question is not solvable. But why I am taking it up? You have a hypothesis, and if you want to confirm or refute the hypothesis, you have to test it. And that is basically what evidence-based is all about. In the case of stroke, there are so many questions which can be tested. And just like in the case of rice and potatoes, there are also so many questions which you cannot answer with randomized trials. And in that case, you take the best evidence whatsoever is available. So I will come back to that a little bit later, but we will move on to stroke now. Well, just like Dr. Deep said, the story of modern stroke is really revolutionary. It used to be a mystical disease where a normal person suddenly get a sudden neurological deficit, and there was nothing you could do about it. So those patients used to stay in their house or sometimes in a nursing care center. And from the 80s and 90s, we started admitting stroke patients because there were some evidence saying that if you control their blood pressure, blood sugar, etc., there could be a better outcome. Now, from there, we went on to the next level, which is an emergency management. Now, stroke is considered as one of the 3 most prioritized emergency disease. Okay, apart from MI and trauma, stroke is the next leading emergency disease. So it's a drastic change in the last few years. And we will see how we came there through the eyes of evidence-based medicine. Let's see. Well, whenever we talk about an ischemic stroke, we have to know a little bit of anatomy. And as you know, we have the circle of Willis, and we have a few large vessels and few small arteries in the brain. And whenever you have a thrombus or a blood clot, which probably get dislodged from carotid artery or from the heart, it will end up getting stuck in one part of the middle cerebral artery. For example, you get a large vessel stroke. Now, there is also another kind of stroke where the thrombus itself is made in a small artery, one of these end arteries, and it can give what we call a lacunar stroke. About more than 50% of strokes are of lacunar stroke, which happens because of this small thrombus. Now, why is it important to differentiate? Because the treatment could also be different based on whether it's a large vessel stroke or a what we call a small vessel stroke, a lacunar stroke. Now, when you have a thrombus in the brain, what happens? Well, you can imagine that the cerebral blood flow would go down that area of the brain which is supplied by that particular vessel. So let's see. So you have a clot there, and the cerebral blood flow, which is measured as millimeter per 100 gram per minute, and the blood flow goes down from, let's say, 50 is the normal, to 20. And when you reach there, when you have a blood flow of 20 milliliter per 100 gram, you get what we call an electrical failure. The neurons stop acting. The membrane is intact, but there is an electrical failure. And that is when you get paralysis or aphasia or any stroke symptoms. Now, let's say that the blood flow reduces further to 10, then you get what we call the membrane failure. The whole cell membrane of the neuron, it gets disrupted, okay? And when you have a disruption in the membrane, the cell is dead. But you have a tissue where you have a blood flow between 10 and 20, you call it penumbra, which means that that part of the brain is no more functional, but it is not dead. It's going to die if you don't do anything about it, but it's not dead yet. So that's what we call the penumbra. And whatever we do in acute stroke, it's all about saving penumbra. Okay, so here you have a core area where the blood flow is very low, and that part is dead. That is what you see in the red. But surrounding that, there is a huge area where the blood flow is low, and the neurons are not working, but they are not dead. So if you save that area becomes functional again. So that's the basic principle behind the stroke management. So what happens at the cellular level? Let's see that if the blood flow is very low, it's less than 10, then the cell membrane get the message that the cell is going to die. It will recruit leukocytes and other inflammatory cells, which will take over. And finally, the neurons will have a very dirty end with a lot of inflammation surrounding them and leading to necrosis. Whereas if the blood flow is somewhere between 10 and 20, even then the nucleus get the message that something is wrong. Okay, so the blood flow is low and maybe I'm going to die. And then the nucleus itself will produce some proteins so that you can have a peaceful death. In that case, this is what we call aponeurosis, right? It's kind of a suicide, you can say. But this is a long-term process. So here you don't have all the inflammatory markers, you don't have all the inflammatory cells coming and attacking the neurons, but the neuron itself is preparing for its death. And this is a long process. So you have a window here where you can actually treat the problem. And is it possible to measure or show whether penumbra is there when you have a patient in the emergency room? Well, it is possible with the newer imaging modalities. So here, the middle three pictures, you have what we call a CT perfusion. And on the right side, we have something called cerebral blood volume. The dark area here, the volume is very, very low, which means that this area is completely dead. But see the area surrounding that. Here, this is something called cerebral blood flow. Here, the flow is low, but the tissue that is already dead is much, much smaller than the area which is under threat. So in this patient, you have a large penumbra. Some part of the brain is already dead. You can't do anything about it. But there is a large penumbra where you can do something and make a change. And when that happens, the area of the brain which is in a penumbra phase, 2 million neurons die every minute. So time is very, very critical factor. You are spending so much time examining the patient, thinking what to do. Every minute, 2 million neurons are dying. So this is an emergency situation, right? And what would happen to this penumbra? Well, it will depend a lot on the patient factors itself and a lot on what you do. And we know that there is a thrombus sitting there. So the pipe is blocked and you have to somehow remove the block. That's what we call recanalization, right? And in the case of intracranial blood vessels, the nature itself has some process where it would try to remove the block. So in the case of middle cerebral artery, if you have a block, if you have a thrombus, there is about 18% of chance that it will recanalize by itself within 6 hours. In the case of smaller vessels in the periphery, you have a better chance of up to 24%, which can get better by itself. But that's not good enough. So in those patients, if you're going to use IV thrombolysis, you increase the chance from 24 to about 46%. As a group, I'm not talking about an individual patient, as a group, you can double the chance. The large thrombus, which are sitting in the middle cerebral artery, where the chance of a spontaneous recanalization is only 18%, you can maybe go in with a catheter and remove the thrombus physically, which we call mechanical thrombectomy. And there, the chance for recanalization is much higher, 87% as per this study from 2001, but with better and newer device, it could be even higher than that. So recanalization is a primary treatment which could benefit these patients. Yeah, how fast this process happens? Well, we can look at the cerebral blood flow again. If it is very low, the tissue will go into infarct. But let's say that the blood flow is around 10 or between 10 and 20. That area of the brain is in a penumbra phase, but that won't last long. With increasing time, the penumbra is going to be converted into an infarct. So in about 6 hours, most of the penumbra will get converted into infarct. Now, is that applicable to all stroke patients? That 90% of penumbra will get infarct? No, it changes. It varies from patient to patient. But in general, in about 6 hours, this will get converted into an infarct. And what are the factors that actually predict or help you to say whether this patient will immediately get converted into an infarct, or this patient is going to have a long penumbra phase and the conversion to infarct happen after some time? That's when the collaterals come into play. So we have the circle of Willis in the brain, and as we can imagine, the blood come from, I'm sorry, let me put on the light. It just went off automatically. Sorry about that. So you have blood flow coming through internal carotid artery, and it goes anterograde into the middle cerebral artery. You also have other blood vessels which are coming into or off from the middle cerebral artery. So you have the ophthalmic artery going from the carotid, internal carotid artery. You have an anterior cerebral artery going off from the carotid, and you also have what we call the posterior communicating artery. But let's say that a thrombus comes and sit in the carotid artery, then all these blood flow could reverse so that there will be more flow to the middle cerebral artery. We also have something called a leptomeningeal collaterals. These are very small collaterals which can also come into the play. This is a mouse model, of course. And we also have a leptomeningeal collateral. And some people are having better collateral, some people are having poor collateral. It could be something to do with genetics, it could be something to do with age, it could do something to do with other comorbidities like diabetes or hypertension. But some people have good collateral, and they are likely to have a longer penumbra phase. So there are two factors which are very important. One is how fast you can do the recanalization. Second is how good your collaterals are. Okay. And I will take an example here. So this is a patient who is having a middle cerebral artery thrombus sitting right here on the left side. And if you look at the periphery, you can see that the collaterals are very poor. There are very few small vessels here. Compared to the other side where there are a lot of collaterals, here there are only very few collaterals. So this patient was treated, and you see the infarct on the picture on the right. We can see that a large part of the brain has become infarcted in spite of treatment because the collaterals are poor. Now let's take another patient. Here there is a middle cerebral artery thrombus sitting on the other side, which is the right side here. And if you compare the collaterals, it's not the best, but it's okay. So here he has somewhat good collaterals. It's not as good as the other side. He has somewhat good collaterals. And this patient was also treated, and he ended up having less infarct. So collaterals are very important thing to consider. And coming to how fast we should treat the patient, we have to look again into evidence-based medicine. We know that we have all these IV thrombolysis agents, but do they work? If they work, how fast do they work? And this is a pooled analysis of all the clinical trials done in IV thrombolysis. On the y-axis, you have what we call an odds ratio for a good outcome. So higher odds ratio means better outcome. On the x-axis, you have the time from onset to treatment. So as you can see, if you get a patient within 90 minutes and you get IV thrombolysis, the odds ratio for that particular patient to have a good outcome is more than 2. So you increase the odds by more than 2. And the dotted lines on both sides are what we call confidence interval. Okay, so when we have a study and we have a result, the result may not exactly be true for the real patients. So that's why we use the confidence interval. And as long as the confidence interval is over 1, then it's okay. And as the time goes, the line comes down. And once you reach 4.5 hours, the lowest confidence interval reach 1, which means that any treatment after that, you are not sure whether it's going to help the patient or not. So as per the evidence we have today, based on multiple randomized studies, we can say that IV thrombolysis is effective if you have the patient within 4.5 hours. In a very particular patient, let's say that a 25-year-old patient comes with stroke and he reaches the ER in 5 hours. He has very good collaterals, very good brain, very good blood circulation. Maybe he will benefit from treatment after 5 hours, but we don't know. We don't have any evidence to say that. So all the major centers, they wouldn't do IV thrombolysis after 4.5 hours. But it's also important that you treat them as early as possible. And sometimes this odds ratio can be a very tricky number. People may not understand it so well. And then we can use something called a number needed to treat. And what is number needed to treat? So let's say that the patient comes within 90 minutes. And if you treat 2 patients, you can guarantee that one of them will have very good effect from the treatment that you offered. So you just need to treat 2 patients and one of them will have a very good outcome. And when the time goes to 3 hours, 188 minutes, you would have to treat 7 patients to get very good outcome in 1 patient. So it's a very time-bound treatment, okay? And as you can see, when the time goes to about 3 or more than that, the efficacy of the treatment also goes quite down. You have to treat maybe even 15 patients to get 1 patient in good shape. And that process is also dependent on the size of the thrombus. So here we have recanalization rate on the y-axis, and this is the size of the thrombus in a middle cerebral artery. So if we look at the chance for recanalization, if you have a small thrombus, let's say 2 millimeter, and you are using IV thrombolysis within a reasonable time, the chance for recanalization is very high. But let's say that the size of the thrombus is about 5 millimeter, which is again small. The chance for thrombolysis is about only 50%. And the average thrombus sitting in the middle cerebral artery is about 12 millimeter. So if you come to about 10 millimeter, the chance for recanalization is almost 0 with IV thrombolysis. And then you need some other treatment for those patients. So let's say that you are a physician or a neurologist in a hospital. You have a patient who comes in with a dense hemiplegia. He has a lot of weakness, but it could still be a lacunar stroke, a small thrombus sitting in the lenticular-striate arteries, giving a dense hemiplegia. Or it could be that he has a large thrombus sitting in the middle cerebral artery, giving you a dense hemiplegia. Can you use your clinical expertise to say whether this patient has a small thrombus or a large thrombus? Well, if you're very good, maybe in some cases you can differentiate. But in most cases, it's not possible. Let us say that we look at NIH stroke scale, which is a scale to assess the severity of the stroke in a particular patient. The scale goes from 0 to 42. And let's say that you have a patient with an NIH stroke scale of 4, which is very mild stroke symptoms. So let's say that you have dysarthria and mild facial weakness. You can easily come to an NIH scale of 4. And in that particular patient, what is the chance that that particular patient has a large thrombus in the middle cerebral artery? It is not 0. Even in such mild patients, about 10% of those patients has a large artery thrombus. So our clinical tools are not good enough to diagnose a large vessel thrombus. And we know that large vessel thrombus, IV thrombolysis is not that effective. And that is why you would need a CT angiography. So you could be sitting in a peripheral hospital where you have a CT facility, you have IV thrombolysis facility, you do a CT scan, a plain CT scan, there is no bleed, you can give IV thrombolysis, which is very good, but not good enough. Because it could be a patient who is still having a large thrombus and you need to use a CT angiography. to rule that out. Now coming to the agent itself, okay, which all medications are available for us to do thrombolysis? We have mainly two type. One is called alteplase. I think I'm hearing a lot of noises. So if any of you have not
Noted, sir. I have
mute
noted
function,
it.
please do that.
I have noted it.
Thank you. Thank you. So we have two agents here. One is the older one called alteplase, and the other one is called tenecteplase. Alteplase is given as an infusion because it has a short half-life. So you have to give it as an infusion over 1 hour. Tenecteplase has a longer half-life, so it can be given as one bolus. Alteplase is fibrin specific, which means that it will go to the blood clot and it will act on the fibrin in the blood clot. It's specific, but it's not as specific as tenecteplase. And there are also some animal studies suggesting that alteplase could be neurotoxic in a very minute level, but tenecteplase is not toxic. So at least on paper, you have a better agent called tenecteplase, which can be given as bolus, which is a great advantage on the practical level. But actually, is tenecteplase better? We don't have enough data on that. And that's when we came up with one randomized trial here. And we were fortunate to have it published in Lancet. And this was the first phase 3 large randomized study. So we put patients into tenecteplase or alteplase. We had about 1,100 stroke patients. And then we looked how did they do after the treatment. How do you assess whether they did good or not? You can assess their functional status by using a scale called modified ranking scale. We don't have to go into the details, but if you have a scale from 0 to 1, those patients are doing extremely well. They may have some mild symptoms, but they are completely independent and they don't need anyone's help. So we looked at the number of patients who did very well after tenecteplase and alteplase. Yeah, about 2% of patients who received tenecteplase had a better outcome than alteplase, but this is not statistically significant. So we did not find that tenecteplase is superior to alteplase. But we also looked at the complications rate. We used a relatively high dose of tenecteplase at 0.4 milligram per kilo weight, and there was no difference in the bleeding rate between these two agents. So tenecteplase is definitely safe. Whether it's better or not, we cannot conclude from this study. But you also have to sometimes look into the details of the study. We had a very liberal inclusion criteria here. And what we did was that all patients, even with minor stroke, they were all included in the study. So we ended up with a lot of patients with minor stroke. And when you have a minor stroke, regardless of the effect of the medication, they are likely to do better. So you are not able to show that difference when you have a lot of mild stroke patients. So what we did after the study was published, we did a post hoc analysis. We chose all the patients who have a moderate to severe stroke and look how did they do. And the patients who were on tenecteplase, they had a far better outcome. You know, there was a difference of 7% between those who received alteplase and tenecteplase. So now we are doing another study where we recruit only patients with moderate to severe disability or moderate to severe neurological symptoms at the onset, and then we randomize to see if actually tenecteplase is superior. But until this is proven, I think it's very prudent to use or choose tenecteplase over alteplase. I understand that in India, tenecteplase is cheaper. Here it's the opposite because of the patent and all those things. We pay more for alteplase. but I hear that it's cheaper in India. And it's a bolus, and it's likely to be superior than alteplase, but I cannot say that because based on the evidence we have, I don't have anything to say that it's superior, but it's likely. So in my mind, it's probably very prudent to use tenecteplase than alteplase in India, at least in the Indian settings. Now we talked about those patients who are having a large thrombus. IV thrombolysis is good, but not good enough. So then people started thinking about the next thing that cardiologists used to do. They would always go with a stent and remove the thrombus or do the stenting. So neurologists also started doing that already from the 2000s. But until 2015, we had multiple randomized studies. All of them showed negative results. None of them showed any benefit of thrombectomy until 2015. And just like Dr. Deep said, from 15th onwards, we have had multiple positive randomized studies. So how can you explain that? How come some studies showed negative results and from 15 onwards we are having positive results? It can very well be explained logically because with modern treatments and modern stent, our technique has become better. Our stroke logistics has also become better. We do more and more of CT angiography. We identify patients early and we put them into treatment early on. So that would explain why since 2015, there came multiple studies which showed a great benefit. Now, how great is the benefit? These are the main studies that were published after 2015. All except one showed that mechanical thrombectomy was statistically superior to standard treatment. So here on the y-axis, you have patients with good outcome. The red columns shows patients who did not receive mechanical thrombectomy. In other words, these are patients who received standard treatment. And the blue columns would represent the proportion of patients who had a good outcome. So if you lump together all these studies, patients who did not receive thrombectomy, about 30% of the patients had good outcome. But if you subject them to mechanical thrombectomy, you could elevate that into about 55%. Okay, so about 1/3 of patients are going to do fine anyway. But if you do thrombectomy, you can increase that to about 55, not more, not less. Okay, but that is a considerable number of patients. So about 1 in 4 patients, you can make great difference using mechanical thrombectomy if done within 6 hours. What about patients who come after 6 hours? Okay, this was unthinkable a few years back. We talked about this, right? In about 6 hours, most of the penumbra get converted to infarct. So any treatment after this, it would lead only to complications. But this is what is the general fact. This does not apply to all the patients. And if you have a young patient or if you have a patient who is doing generally well, maybe his curve look like the one below here. Maybe he or she has very good collaterals. Maybe he is having a very good genetic makeup that would allow his collateral to be very rich. And therefore, that conversion from penumbra to infarct is a much longer process. It may be hours or it could even be days. So if you can identify this group of patients, even though it has gone more than 6 hours, you could offer treatment. Well, the question is whether it would work or not. And again, we have to do studies to prove or disprove that. Because our personal observations, it doesn't have much value. Okay. I have a patient who came in after 20 hours. I did a thrombectomy, or my interventional radiologist do a thrombectomy, and he did well. Well, this medication work. No, you can't conclude like that, because there could be 10 other patients out there who did not get benefit or even got some side effects from the treatment. So you have to again do a randomized study here. And of course, here after 6 hours, you have to very carefully select your patients. You have to make sure that they have some penumbra even after 6 hours. Now, this can be done in many different ways. You can do, say, CT perfusion. Sometimes you can do an MRI. And sometimes people assess how the collaterals are. If the collaterals are very good, then they would assume that they have very good penumbra and then go with the treatment. So there are different ways of assessing it, but regardless, after 6 hours, you have to identify that. So in 2018, there came two studies called DAWN and DIFFUSE studies, where patients were randomized into mechanical thrombectomy even after 6 hours, even on up to 24 hours. Of course, they assessed whether they have a penumbra, which can be saved. But what is very interesting here, on the left, you have all the previous studies where they did thrombectomy within 6 hours, and see the difference. The yellow column shows the number of patients who did well with mechanical thrombectomy. Yeah, there was about 25% betterment in patients who received thrombectomy. What about those who came after 6 hours? There the difference was even higher. So it's kind of a paradox, right? People came late, they got mechanical thrombectomy, and they did even better. It's not really a paradox because they chose their patients very carefully with the penumbra imaging. But it shows that it does work. So you could be having a patient who come even after a day and still have good effect from thrombectomy. Right? This is a revolutionary. One patient who had a stroke yesterday and coming to you today, and you could still do something about it. This is great time for strokeologists because we can offer something that is very promising for the patients. Of course, we are talking about a very small proportion of patients here. Okay, maybe about 10% of less than 10% of stroke patients come in this window who may benefit, but it's still possible and you have to make that assessment. So Dr. Deeb again talked about time is brain concept. Time is still brain. And on the left side, this is the billboard. I took a picture from Believers. They have this billboard to make people aware of stroke symptoms and how fast they should act. Very good. So is it still applicable? The time is brain. Do they have to come early? Do they have to come within 6 hours, or can they wait and then come next day and get the thrombectomy? No, you still have to come within a certain time window, but there is a group of patients where the capillaries will decide whether they can get the treatment even after 6 hours. So based on that, based on all the evidences we have, based on all these studies, how can we set up our stroke logistics? Okay, you have to have a system so that things happen fast. So every hospital or every institution, they have to have their own standard protocol. It could vary from place to place depending on the resources available and depending on how people come, etc., etc., etc. But you have to have a protocol. So based on all these studies, the protocol that we have here is like this. If the patient comes within 4.5 hours, and if the patient has a measurable neurological deficit, which means that the patient has a weakness in one arm, or let's say patient has an aphasia, we would consider them for thrombolysis. It may be mild deficit, but we would still consider them for thrombolysis. Then we will get a very fast CT and CT angiography, which means that we will never use more than 5 minutes to take the history and examine the patient, because every minute you are losing 2 million neurons. So we would go for a very fast CT and CT angiography, and then we will go for a thrombolysis. Why are we doing CT angiography? Because we want to see there are patients who have a large vessel occlusion, right? Those who are having a large thrombus in the middle cerebral artery, and then we have to send them for mechanical thrombectomy. And if you're working in a smaller hospital, you can do the thrombolysis and then refer them to the next stroke center. And what about those patients who come after 6 hours? There, we don't treat every patient who come after 6 hours. If they have a mild neurological deficit, you probably don't want to subject them into what we call mechanical thrombectomy, where we have to go in with a catheter through all these arteries and then take out the thrombus. And there, you would expect that. Sorry, we have a sensor here, so if I'm not moving around, the light will go off. So you have to make sure that the patient is having some neurological deficit. So you select those patients who are having moderate to severe deficit. Then you take a CT, a plain CT, to make sure that there is no bleed. Then you take a CT angiography to see if they have a thrombus. And on top of that, you take a CT perfusion to see if they actually have a penumbra which can be saved. And if you have a penumbra on the CT perfusion, then we will go ahead with mechanical thrombectomy. But this group of patients, you can't have thrombolysis because that could be very dangerous. They can bleed into the infarct. So this is the protocol that we have developed here. And I think the protocol that they have in BCMCH is also somewhat similar. There could be some minor differences, but if I understand right, it's somewhat similar to this. So after boring you with all these hardcore theories and all the studies, I think I will take you to one case that we had here. So here is a young man, a 40-year-old man. He have had some previous episodes of bradycardia, and he was actually worked up for that, but cardiologist did not find anything wrong. So one day he suddenly had a dizziness, and he had a transient loss of vision in one of his eyes, on the right side to be clear. And following that, he developed weakness on the left side of the body, and he had a facial droop. He came to the ER within 2.5 hours. And during that time, some of his symptoms receded. So when we examined him, he had only an NA scale of 3, which is a mild stroke. What he had was only a dysarthria and a facial droop. He did not have any major weakness. He did not have any cortical signs like neglect or a speech problem or aphasia. So he had only mild symptoms. Of course, if we go with the normal protocol, you get the CT angiography, and you can consider him for IV thrombolysis. So we followed the protocol, and surprisingly, this patient had a large thrombus sitting here on the right middle cerebral artery. Now, clinically, can we explain all his symptoms? Strange symptoms, right? Dizziness, loss of vision in the eye, and then weakness. Well, it can all be explained very well. This patient very likely had a cardiac emboli. It traveled through the internal carotid artery. It came to a place where the ophthalmic artery goes off. That would give him a transient loss of vision because the ophthalmic artery got occluded there, and then he got loss of vision. The emboli further traveled distally, and it finally ended up in middle cerebral artery, giving weakness. So how come his weakness got better? When you did the CT angiography, he still has a thrombus here. Well, this is a young patient. His collaterals are very good. So the collaterals took over here. It started to supply those areas which were having less blood flow, and his symptoms got improved. So here comes the question. What would you do further? We did a CT perfusion just to see what is happening. And on the right side, you have what we call the cerebral blood volume to see if there is already an established infarct, and we see nothing here. On the right, there is no infarct. But look at the cerebral blood flow. There is a large area with less blood flow than what is needed. So it's possible that some natural recanalization happens, maybe facilitated by IV thrombolysis, and we can save this area. Or it's also possible that the thrombus sits there and the collaterals get fatigued after sometimes. Collaterals will disappear and this area will go into become infarct. So what would you do? Would you use a regular aspirin and wait and see how it goes? Would you go ahead with IV thrombolysis? Or would you go ahead with mechanical thrombectomy? It's a difficult choice here. I think in India, you would definitely discuss that with the family, and the family would finally probably decide what to do. But here, it's the system that take care of the patient. You really don't have to talk with family and get their consent because it's not the family who pays. You definitely have to get a consent from the patient, but we can decide. So if we, for example, recommend mechanical thrombectomy, the patient would definitely agree with that. But whether we should do or not, it's a difficult choice. It's a young patient. Maybe he will do fine by a natural recanalization. And in that case, you would avoid all the complications that can potentially come with mechanical thrombectomy. It's a hard case. Well, what happened? We give him IV thrombolysis. We decided that we will see what would happen. Probably not a good option, but anyway, that's what they chose here. So he went fine. He was admitted here. And on the second day, he developed a sudden hemiparalysis. And he had cortical signs. He had neglect. And when we assessed the NIH stroke scale, it was 21. A new CT angiography and CT perfusion, the thrombus is still there. And fortunately, he had a large penumbra even then. Even after one day, the penumbra is there. There is more infarct, but the penumbra is still there. So what would you do? Yeah. Now we have a young patient who has a thrombus, and there is still penumbra. And the patient did not do well with IV thrombolysis. So in this patient, on the second day, we went ahead with thrombectomy, mechanical thrombectomy, and he did well. He was discharged with minor weakness. Retrospectively, if we look into the whole case, maybe it would have been better to do mechanical thrombectomy. But it's always easy to say things retrospectively. Okay, we have also had cases where there were large thrombus sitting in the internal carotid artery and things went fine with IV thrombolysis. So it was not an easy case. But I am just showing it to tell you the complexities involved here. You have to think, you have to look at evidences, and then you have to proceed based on the best evidence available. So all this happened in the last few years, right? So we started out with no treatment. Then we started with IV thrombolysis, which can be offered until 4.5 hours. Then came the mechanical thrombectomy, which was approved until 6 hours. Now it is approved until 24 hours, at least in a small population of patients. So it's a great change the way we are treating stroke patients now. So what is coming in the future. We are certainly not going to stop there. There could be more exciting treatments that are probably coming. This is an ambulance we have in one of the hospitals in Norway. And this ambulance has a CT scan inside the ambulance itself. Okay, this is not a standard treatment, of course. This is run as a research project to see if we can actually give thrombolysis already on the way to the hospital. We take a CT scan, make sure that there is no bleed, and then the patient would get IV thrombolysis. You have one doctor and you have one ambulance person in the ambulance. This is something called mobile stroke units. And there was a big study from, relatively big study from Germany where they did the same thing and they came out with a result. And the results are exciting. They could do the IV thrombolysis earlier. And there was also a trend showing that they were doing, those patients who received IV thrombolysis earlier in the ambulance were doing better. So this could be the future, but we are certainly not there yet. Now, this requires a lot of change in attitude, right? We were very slow with stroke because there was nothing to do. And now it's a very emergent condition. So traditionally, a neurologist is seen as someone who goes around with a reflex hammer, make a very thorough neurological examination, and comes up with a diagnosis where he or she could say that the problem lies in the right basal ganglia or the left internal capsule or the left pons. But we can't work like that anymore. You don't have the time to do all those intricate clinical examination. You have to get rid of your reflex hammer and you have to make a very fast assessment in the emergency room. And then you have to have a very coordinated teamwork so that the patient get a very fast treatment. It has to go almost like what happens in, let's say, in Formula One race. Okay. So as you know, in Formula One, you have to change the tires very often. And let's see how it happens. The car comes in and the team is ready, and there are multiple teams who all know what their function is, and see what happens. Well, 3 seconds, all the tires are changed. This is what we call teamwork, right? And this is what we need in stroke as well. You need a protocol, okay? You can't have this if you don't have a protocol. So whether you are in a small hospital or a big hospital, you need a protocol, and you need to have a proper channel to refer the right patients to the next center. So it requires a great change in the attitude where a great change in attitude in how we treat these patients. And I think I will stop there, and all these webinars will be interesting only if we have some discussion. So I think I didn't take more than 45 minutes here, and I will stop here. Let me just take to the last slide. This is where I am working. It's a relatively small city with about 50,000 people. It's called Trondheim in Norway. And this is where our hospital is. It's inside the city. And we have a very coordinated system where patients from all over the region come up here, either by ambulance or by helicopter, and we provide a stroke care. So I think I will stop there and hand over the mic to the moderators.
Thank you, Dr. Tito. I think that was a wonderful session. Thank you so much. May I request Dr. Deep to take over the moderation? We had Dr. Anil Kumar with us, who has just left because he just had a code stroke in the hospital, and he has just gone to take care of that patient. So may I request Dr. Deep to start off with the moderation?
Yeah, sure. So it's exciting that we had a code stroke in the middle of a stroke webinar. And hello, am I audible?
Yeah.
Yes, you are. And can you switch on
Yeah.
your? Yeah, that's perfect. Yeah.
As I was saying, it is exciting to have a code stroke in the middle of a stroke webinar. Hope everything turns fine there. Tito sir, thank you very much for enlightening us with those treatment journey that you had, and what has happened over the last 25 years is really exciting, as you said, and we definitely have exciting times ahead of us, because acute stroke management is not going to stop here. Things are going to evolve, and we can expect more and more uh, life-defining changes, if I'm not wrong, that will happen in the next 5 years of acute stroke management. So with that, I will take the first question that is in the chat box. So our participant would like to ask, what are the indications of decompressive craniectomy, and what is your protocol at your center?
Yeah, that's a great question. Acute stroke, I didn't go into the surgical part of it. Now, we have seen that there are patients who come in with a large thrombus in the middle cerebral artery or somewhere else. And we have some treatments, okay? Sometimes we are able to go in with a catheter and take it out. It does not happen all the time. So if you have a patient who has a large vessel occlusion where the treatment was unsuccessful, or following the treatment, patient bleed into the infarct, and you have a threatening herniation of the brain, that's when you have to go for what we call a hemicraniectomy. Well, we thought that hemicraniectomy do save life. It does not save the neurons or the brain, but it saves life because you can avoid the herniation. So you take off the part of the skull and relieve the pressure in the brain, and then later on you put back the skull. But recently a new study came out which showed that even you may even be saving some neurons as well, because those patients who had an early hemicraniectomy, they were doing better than patients who did not have. So the indication for hemicraniectomy is when you have a patients with a large vessel occlusion where you have developed a large infarct, which is going to develop edema and going to herniate. And in that case, you have to do hemicraniectomy within the first 2 days. So if you wait with your patients, it's not going to help. Then it's too late. So the first 2 days, you have to make an assessment whether this patient has developed a large infarct and is going to herniate. That's when you can go for it. Did
Sorry,
I
sir.
answer the question?
Yeah, sure. Hello. Okay. So I would like to ask one question from my side. So what is the how do you consider approaching wake-up strokes?
Yeah, that's another topic I didn't touch because of
No,
the
sir. Briefly, if
time
you can.
concerns.
Yeah, I understand. But briefly, if you
Yeah.
can.
Well, in the case of wake-up stroke, the big question is whether patient slept through the night after having a stroke, or the patient actually woke up because of the stroke symptoms. So if the patient actually woke up because of the stroke symptoms, then the time at which he or she woke up is the symptom onset. But that's not always easy to understand. But if you look at all the case series, And maybe you even have a personal experience that when you do the imaging of all these patients who come up as wake-up stroke, you usually don't have an established infarct. And there is probably some physiological explanation as well, because we know that blood pressure and all the stress hormones starts to go up early in the morning. And maybe that's what triggers a stroke early in the morning. So in general, most of the patients who come up as wake-up stroke, they did not have a stroke in the middle of the night. Most of them are woke up with stroke. And in that case, it's probably safe to thrombolyze them, but you are not 100% sure. So what we do here, we would go ahead with an MRI protocol in those patients who come in with stroke. And if you have already a large established infarct, naturally we won't do thrombolysis. But if they don't have a large infarct and if they have a large diffusion deficit, then we would go ahead and do the thrombolysis. The second option we have is we have a research protocol going on. What is it called? TWIST study, where we would randomize the patients into either tenecteplase or placebo. And here we would basically look if they have already an established infarct. If they don't have it, they would either get tenecteplase or placebo. Sometimes we think, is it ethical to do that? Because 50% of the patients would get only placebo. But at a time when you have to prove everything, it's needed to have such studies where we can say safely that it's okay to do thrombolysis even without an MRI. So we have these two options and we choose one of that. I don't know what's your strategy there?
Yeah, we also go ahead with the MR protocol, and then if there is a diffusion flare mismatch, then we would explain to the relatives, and getting them on board, we will offer the treatment for them. Again, perfusion, we don't go with perfusion. If it is a small core beyond the 6-hour window with a large vessel occlusion, then we offer mechanical as well. But again, it is a difficult scenario.
Yeah, but I think it's quite reasonable to do that. Some of the problems are if you have a brainstem stroke, then we know that even MRI is not that good in the acute phase. Apart from that, I think it's a very reasonable way to go, especially if you have the family on board. So I think it's reasonable.
We have one more question in the chat box. So what about patients with CKD, that is chronic kidney disease, on conservative management? Would they also get a CT angiography? Because 5 minutes is not enough for a creatinine level. Would MR with MR angio be enough?
Yeah, that's another very good and practical question. Can I ask what you do there?
CKD, depending on the window, sir, if it is a hyperacute phase, we just say a diffusion and take a diffusion. And if it is a candidate, then we start with a TPA, and then we straight ahead go for the MRI angiogram.
Okay. So you would try to avoid a CT angiography with contrast if you have a patient with
CKD on dialysis patient, we would go ahead with the CT angiography.
Okay. Well, we used to do that as well, but maybe demography is different here and there. I think I haven't looked into the data, but I have a feeling that there is more diabetes and there is more CKD in Kerala and India than here. In fact, there is very little diabetes here. So we in general have people with less kidney problems, but of course there are people who have CKD. And again, here we went through the data for these patients. And patients with CKD, if you give one CT contrast, yeah, you have to treat them with IV fluid. But it is generally considered safe to give CT and CT contrast. Uh, we haven't had any experience where the kidney functions getting permanently worse after contrast, and this is also proven in other larger studies. So we actually don't even look at creatinine level before taking a CT and CT angiography. But if you have a patient who is on dialysis, then it might be different. But all other patients who are not on dialysis, we don't wait for creatinine. The only blood test we do in the acute phase is get a glucose, because sometimes if you have hypoglycemia, they can present with stroke. And the second thing is INR, if the patient is already on warfarin or some other anticoagulants. Otherwise, we don't wait for blood test for thrombolysis. Now, things could be different there because of all the medical legal issues, and you have to take care of the family and all those issues there. Here we don't have to do that. We have to follow the protocol. If we are within the protocol, then we are safe. But I know that things are not so there. If things goes good, very good, but if things goes wrong, then the doctor is at blame. So I guess you have to take into consideration that factor as well.
So we have another question. So, antiplatelet loading, is it required? If it is, how much to be given? I know the context.
Yeah, depend on the context. If you are going for thrombolysis or thrombectomy, then you have to wait a day before you can start antiplatelets. In case of stenting, if you put a stent, then then some of the stents, at least here, they would start antiplatelet quite fast. They won't wait a day. But at least in the case of IV thrombolysis, you have to wait 1 day before you start antiplatelets. If you are not giving IV thrombolysis, if the patient came very late, then you of course give aspirin. Then we load them with 300 milligram of aspirin, and then from next day onwards, we will go ahead with aspirin or Plavix.
So you load with a single antiplatelet.
Yeah, in the case of major stroke, but based on a new study which showed that double platelet for patients with minor stroke is beneficial. So if you have a patient with, let's say, NIH stroke scale less than 6, then we would actually load them with both Plavix and aspirin and use that for 6 weeks and then convert them into just a single therapy with Plavix. That's what we do.
If you are loading with the dual antiplatelets, Plavix, what would be
Yes.
the dose, sir?
Yes.
What would be the dose of Plavix?
300 milligram both.
300. Both 300. Yeah.
Correct.
We have another question. After IV thrombolysis, if the patient is normal, any role, again the same question, any role of for dual antiplatelets?
Well, I think we have to differentiate these two things. IV thrombolysis is just the acute treatment, and platelets, yeah, antiplatelets. If you give a loading dose of aspirin, it has some effect, but basically all that we talk about double antiplatelet, it's for the recurrence of stroke. So even in the study where they used double platelet in the acute phase, I mean, after the 1 day, it was to look at the recurrence, and there was a slight reduced recurrence in patients who received double platelet in the coming few weeks. So so I don't think we have to get confused between IV thrombolysis and double antiplatelet. This is to prevent recurrence. Double antiplatelet is to prevent recurrence. Do you agree, Dr.
Yeah, we
Dr. Deep?
usually start with the antiplatelets after 24 hours at a repeat CT, as you said, sir. When especially when IV thrombolysis was given, and then we would initiate single or double antiplatelet depending on the residual infarct load. So if it is a large infarct load is there, then we might be not that comfortable starting dual antiplaytics right away.
Yes, yes, agree. If it's a large one, then it's always better to stay with one.
Especially the surgeon also will be happy if the patient is not on clopidogrel.
Yeah.
Because if he has to take him for heavy craniectomy.
Well, do they differentiate between aspirin and Plavix? Are they happier if the patient is on aspirin?
I think from their point of view, clopidogrel is more dangerous.
Okay, okay.
Let me see if there are any more questions. I think questions have been taken. Sir, you in your center right now, you're using tenecteplase more or alteplase more?
Like I said, we have this randomized study.
Yeah.
We randomize them to either tenecteplase or alteplase if they have an NIH over 6, patients with moderate to severe disability. So those patients, we take them into the study and then they will get one of that. Other patients, we are using alteplase because, that also varies from center to center. Here we are using alteplase. But all the patients with moderate to severe stroke, they get randomized to one of these studies, one of these
What is the dose
medicines.
What
Yeah.
is the dose of tenecteplase?
Yeah, that's again another maybe a controversial topic. Most people are comfortable with 0.25, but as you probably know, the study that we conducted, we use 0.4, and it was found to be safe. So the newer study that we are conducting, it's still 0.4. And as you know, cardiologists are using a dose of 0.5. So I think it's reasonably safe to use 0.4. I don't know if Indian patients are particularly susceptible to bleeding than here. I'm not sure if they bleed more after an infarct than patients here. I'm not sure. But anyway, in our experience, 0.4 is safe.
I think there are no more questions now. Anything more you would like to add, sir?
No, I'm really glad to have seen you all here. Thanks for all the questions. Thanks for involving me here. So we will keep in touch. Thank you very much.
Yeah, sure, sir. Thank you for a wonderful time, sir. Thank you for the evening. I hand over to Dr. Jacob.
Yeah, Tito sir, I have a question for you on behalf of our students, on behalf of our medical students.
Yes.
How was your journey to Norway? How did you land up in Norway? Of all the countries, most of them going to United States or the UK and probably Australia. So this is a question from our student, one of our students who has written to us. Can you please ask sir about his journey? If you can share in a few minutes, it'll be really beneficial for our kids.
Yeah. I think I'm probably the only Malayali doctor here. It's not the normal place for people to end up because you have to learn the language here. You cannot work speaking English here. For me, I went for my specialization in US, and then after my specialization there, I went back to Norway, not particularly because I was looking forward to work here, but I also have a wife who was brought up here. So we decided to move in here because it's quite a family-friendly place. You have to say that.
The living index is very high, right? The happiness index is supposed to be very high in Norway.
Yeah, that's true. It was on the top, but now I think it fell down to second or third place. Yeah, generally everything is taken care of by the government, and the government makes sure that people don't overwork. For example, even doctors, they are not allowed to work above a certain number of hours every week. So yeah, I mean, quality of life is pretty good. So.
All right. So our children do have a chance to come to Norway. So probably they can ping you if you're interested in coming there.
Certainly, certainly. You know, come in to see Northern Light if you don't care about the cold, or come in summer to see midnight sun. Both are possible.
Wow. All right, sir. So if there are no more questions, I think we can wrap up this session. So I would like to extend my immense gratitude to Dr. Tito Edikula, sir, for coming online for us and sharing with us those crucial perspectives on stroke. It's been a great 1.5 hours with you, a wonderful ride of the management of stroke. I think it will be really beneficial for our students and also for all the delegates from across the nation. Thank you so much. Thank you for coming for this session.
Thank you. Thank you so much for having me. Thank you.
And I would also like to thank our moderators, Dr. Deep Pillai and Dr. Anil Kumar, for ably moderating this session. And thanks to both of you. And special thanks to all our delegates, especially our students who have come in, and postgraduates and doctors who have logged in. Thank you so much. It's been a great evening. So until we come back with a very impactful session next week, signing off from Believers Church Medical College and Hospital. Thank you.
Thank you.
Thank you, Tito.